We have a patient in their 40s who has a history of cutaneous melanoma involving their trunk, and at the time it was resected with surgery, and a sentinel lymph node biopsy was performed, which was negative. This patient was followed. Unfortunately, over time, they developed a mass in their inguinal region, which was surgically resected and found to be melanoma. But additionally, at that time, there was suspicion for additional metastatic disease, particularly in the lung, and an FNA biopsy was performed demonstrating BRAF V600E wild-type metastatic melanoma. Now we have a patient with biopsy-proven BRAF wild-type melanoma in their lungs, and the question is, what is the best initial treatment option for this particular patient? Ipilimumab, PD-1-based immune therapy, combinations of ipilimumab with PD-1 inhibitors, or BRAF and MEK combination treatment. So the first thing to rule out of that list is BRAF and MEK inhibitors in combination. Because this patient does not have a BRAF mutation, BRAF and MEK inhibitors would not be appropriate, at least in that particular combination. So we'll cross off BRAF and MEK inhibitors. The question is, well, what among the various immune therapies would be the best? Since PD-1-based immune therapies have demonstrated improved progression-free survival and overall survival compared to ipilimumab, I think we would take ipilimumab as a monotherapy off the list. So now we're really dealing with, in this patient with metastatic BRAF wild-type melanoma, what's the best initial immune therapy approach? And the question really is, do we give this patient single-agent PD-1 treatment with nivolumab or pembrolizumab, or do we give this patient the combination of a PD-1 agent like nivolumab with a CTLA-4 blocking antibody, ipilimumab? The question of, do you give the combination of ipilimumab and nivolumab or a single-agent PD-1 to a patient with BRAF wild-type metastatic melanoma really remains largely unresolved. And the reason it remains unresolved is because we don't have an overall survival benefit yet for the combination of ipilimumab and nivolumab over single-agent PD-1 type treatment. So really, either of these approaches is entirely reasonable. So how to make a decision in this particular patient? This is a younger patient, presumably without any other serious medical comorbidities, so they probably could withstand the higher rate of shorter-term toxicity of the ipilimumab and nivolumab combination. So if I have an older patient that may have a lot of other comorbidities, may not be so reliable with the communication with the care team, that's a patient I would prefer to treat with a single-agent PD-1 inhibitor in this particular case. However, if it's a younger motivated patient, I would consider this patient either for PD-1 alone or for the combination of ipilimumab and PD-1. We know the combination with ipilimumab and PD-1 has higher responses in terms of by number, and also very rapid responses that can be seen. But the question really is that higher shorter-term efficacy worth that higher shorter-term toxicity? And that's a real patient-specific discussion. Do you want to take a more aggressive approach, a little bit more effective in the short run? We really don't know in the long run if this is appropriate for you. Or do you want a more gentle approach initially to see if it can work, and that would be a PD-1 single agent. So I think there's really clinical equipoise between the combination of ipilimumab and nivolumab and a single agent PD-1 drug like pembrolizumab or nivolumab in this particular patient. And I would just like to add, I really don't see any difference between pembrolizumab and nivolumab as single agents in terms of their efficacy. So I really think a decision between either pembrolizumab or nivolumab is really based on patient preference, feasibility, dose scheduling, that type of an issue. So all of those immune therapy approaches based on PD-1 are reasonable in this particular patient without a BRAF mutation.